exhibition. Now, we want to come back here to the studio and carry on with our conversation of the day. As I told you before we went on a short commercial break, it is the 1st of October 2024, an important day for the Ministry of Health and a new authority that is in town now. It is called the Social Health Authority. Now, the Ministry of Health today is set to roll out the Social Health Insurance Fund to replace the National Health Insurance Fund, also known as NHIF. Slightly over 2 million Kenyans have so far registered under SHA, with the number of Kenyans seen to flock to registration points to beat the deadline. That was the case yesterday. We have a representative here. She will be able to tell us if people are still registering with SHA. Now, the transition to the Social Health Insurance Authority received a boost yesterday from a Parliament's Health Committee where they cleared the scheme, stating that its queries regarding the multi-billion health digitization projects have been addressed. You do remember yesterday the Cabinet Secretary, that is Dr. Baraza, as well as the Principal Secretary for Medical Services, that is Harry Kimtai, appeared before the committee, of course, explaining some of the array of questions that were posed in regards to SHA. The ministry explained that it conducted a pilot program in 8 counties, studying a sample of 2,000 individuals to determine how those in the informal sector will contribute 2.7% of their annual income. And then finally, the Cabinet Secretary for Health, that is Dr. Deborah Baraza, flagged off essential health products and commodities in preparation for the rollout of the Social Health Authority. Of course, employers in the country have been told to remit these funds to the Social Health Authority starting from today. Of course, at the end of the month, you'll be witnessing in your pay slips your contribution you've made to the Social Health Authority. Now, joining us this morning to carry out this conversation is none other than Mr. Olale Ochieng from Ambilex Solution. He is the operations manager, also a clinician. Karibu sana, Mr. Olale.
Thank you so much.
And of course, a representative from SHA itself. This is Julia Ouko. She is the division manager at the Social Health Authority. And then we have a doctor in the house, Dr. Dan Ogola, the CEO and founder of Matibabu Foundation Kenya. And soon, Dr. David will be joining us. He is the deputy chair of KMPDU. Let me start with you, Julia. Where are we as a country right now? I know you're supposed to roll out SHA itself. How many Kenyans, if you know, have so far registered, and how is the progress?
Great. Thank you for having me on the show. Good evening, good afternoon, viewers. Good morning, viewers. Thank you. Because of the rush yesterday, we may not have accurate number, but the numbers are good. The counties are registering in great numbers. There are people flocking in the branch offices, like a last-minute rush. So I am sure maybe towards the end of the day or the week, we will have accurate numbers. But we are looking at millions so far. Yes.
And how are we faring in terms of, is everything ready to go?
Everything is ready to go for now. Yes. The members are accessing services in healthcare. Those who want registration, despite the hitches, is still going on. And any information that you seek from any of our service points, you can be able to get as a beginning. Yes. Because
some of the main issues Kenyans were raising yesterday is in terms of the portal itself.
Correct.
They are unable to register. So has that been rectified?
Yes, just like a new thing, as you start, you get the hitches. So we were experiencing hitches. At times you reach a place where you're supposed to update your dependents, or you have updated. When you go back, you're not seeing them. So all that, as the system interacts with the traffic that is coming, is able to be handled. Yeah, so we are positive about that.
Okay, I'll be coming back to you. Let's get the words from the stakeholders, the people who now will be the first people who will take care of this SHA itself. Let me start with you, Mr. Olale. You work for Ambulance.
Yes.
You are the operations manager. What do you make of SHA, and how will you incorporate it within your organization?
I honestly think it's a good improvement, having read everything or some of the things that they have listed there as deliverables when eventually it rolls out and begins running. So I think it is a good thing to come, but still I think there are a lot of changes to be made, a lot of adjustments, and particularly on public partnership participation. I think that hasn't been done so well as up to this point. By training, I'm a primary healthcare giver, and so I interact with a lot of people on the ground, and I get to hear what they think or what their opinion is about SHIF, everything that so far they know. And I think the knowledge out there is still very little. There's still a lot of myths and misconceptions about the whole thing. So I'll be looking to hear what the government also has to say about that. Yeah.
Daktari, these are patients who will come to your doorsteps. Are you ready to receive them under this new authority?
Yes, despite the hitches that Julia mentioned, yes, we are willing to receive them. Yeah, it's a move in the right direction, despite the hitches that they are in. Yes.
So what's the difference between now SHIF and NHIF you have witnessed as a practitioner?
I'm a health specialist,
yes.
And in terms of hitches, I would rather start by the advantages that we are most likely to get from this SHA. It includes inclusion of certain packages that were not there, such as palliative care services, and I think in overall it's a great move towards achievement of universal health coverage.
Before we get to introduce the stories that we had prepared in terms of SHA, let me come back to you, Julia. Given that you said now you have at least sorted out the hitches that were witnessed yesterday, Kenyans are flocking to these registration points. What else are you doing to ensure at least you have reached the target? I'm sure the target was 12 million. So what have you done outside the box to ensure that you have registered the 12 million Kenyans?
Okay, we've partnered. Our government has made a step towards partnering with organizations and institutions that can help. We have opened up all our networks and branch offices and Huduma centers. We normally conduct registrations at various sites, like if it is a market day, you will find us there. If it is a church, you will find us there. There's also the involvement of the community health promoters who have been assisted with gadgets to help in the registration. So it's, again, the government also involved the national government down at the level where we have the chiefs and the local administration who are also out there in droves within their office setups to encourage the registration drive. Yes.
And as I told you earlier on, the CS as well as the PS for Medical Services, that is Harry Kimtai, yesterday we were before the National Assembly's Health Committee, where they of course brought the committee up to speed on the status of SHA ahead of its rollout, that is today. And of course the ministry has issued a statement in conjunction with SHA itself. I'll be reading out that statement, but we take those stories where it has been prepared in terms of Parliament as well as the procedures that we're going to witness within the new authority.
Okay.
At the stroke of midnight, Kenya will switch to the newly established Social Health Insurance Fund. However, more questions now abound as to whether the departure from the National Health Insurance Fund has been marred by numerous false starts.
Up to this point in time, the ministry has failed to submit to Parliament the signed tender document. For the consortium,
lawmakers questioned the practicability of the means testing instrument which the Social Health Authority targets for contributions by low-income earners.
I wanted to know the intelligence of the means testing. How intelligent is it in terms of what you did? For example, a mama who earns 150 shillings a day, we did the means testing on her, and we found out 2.75% would be there for her, and she will be required to pay annually. So how much money is this mama paying? How are you going to deduct it?
It will be similar to the Hustlers Fund.
How? It will be from the loan. For this kind of.
But 0% interest.
How will you deduct it? From a person? Tomorrow this is
Yes.
Owning a cow
in Githunguri and owning a cow, please don't take offense, in Narok has different income implications. Now we are using about 17 variables, ranging from your source of water, source of lighting, source of power, material building your house, and all those.
If I'm putting the information, all you want to know, you put your information, if you go star 147 or whatever, we put that information down. I get the number I should pay. Is that what is going to happen?
That is correct, Chair.
That is what you want us to tell us. So tomorrow when I go to church, I tell them, ukiweka hii namna hii.
From tomorrow, we'll have two systems. NHIF system will remain. We'll still be processing those claims that were lodged with NHIF, so that system will remain. In a case the law requires that we have to maintain data and records for a period of 7 years.
As I leave this meeting today, I don't have an answer on what to tell people on this 2.75% and where we have been told there will be somewhere they will be keying particular parameters.
But even as the lawmakers demanded more answers, the Ministry of Health, through the Kenya Medical Supplies Authority, flagged off medical supplies and technology to various counties in readiness for the shift to a new insurance regime. Kamche Menza for Prime Edition.
And of course, thank you, Kamche Menza. We also do have a story prepared by Doreen Arange in terms of the new outlook of the Social Health Authority, how much you're expected to pay, and what areas are you like to benefit from, if we could have that story as well. And of course, we'll carry on with the conversation as my producers and directors will be looking for that particular footage. Let me come back to you, Mr. Olale. You've just witnessed the story. The minister was explaining, or the cabinet secretary rather, they're no longer ministers, was explaining the rollout in terms of the SHA itself. From the institution you come from, are you ready to inculcate this to the services that you provide? And what are some of these grey areas you might have witnessed and it can be approved, it can be improved on because SHA is already here?
Well, that is a very good question. So one, from Ambulex, we are very much excited about SHA coming on board because we think there are areas that we could collaborate on. For example, when it comes to providing emergency response. Ambulex has the widest network of emergency response providers in the form of ambulances, EMTs and paramedics. And I know that under SHA there is the emergency critical and emergency and critical conditions fund. So then we could have public-private partnerships with SHA and ensure that those who are especially underserved, because the subscription fees for Ambulex is actually very affordable. It's quite affordable. We're talking about 100 shillings or $1 per month. That's 1,200 shillings in a year for a number of evacuations, either with an ambulance. And you'll remember that not all evacuations have to be, not all emergency responses have to be evacuated. Some can even be discharged on site. And I think this is the kind of partnership that SHA should already be looking to work with. And then in terms of the grey areas that I think are still there, and sorry to mention that this was also witnessed when we had NHIF, I think emergency response was not really well catered for, even in the past. Like, I remember there was a time that guys were bidding for the tender to do emergency evacuations for NHIF. That really never came out clearly, and that's an area I would also like her to really expound on, like, what are the processes this time around? How can a partner, or how can a provider like Ambulex, who has these resources, there's an app, we have the right numbers in terms of all these resources that are required, how can we then partner together?
Daktari, similar question to you, but in terms of solutions, what solutions can you provide to ensure that some of these teething problems can be addressed and ensure that at the end of the day, healthcare is affordable?
Oh, thank you so much. What SHA is presenting, especially from the primary healthcare fund, is where they're trying to implement what is provided in the primary healthcare network guidelines. The government has already produced that. And that will see a situation where we don't wait till health situations are escalated to secondary and tertiary. They're dealt with at the primary level, the point of care. And that, what is envisioned in the primary healthcare guideline is a hub and spoke model, where the community health workers or health promoters are level 1. Then we have dispensaries level 2, and we have other health facilities as level 3. And for level 4, we have which becomes the hub. And so through that, there will be a two-way communication between the community and the health facilities. And in terms of improvement, probably the government would want to pay a lot of attention in the establishment of the multidisciplinary teams that will make this be operationalized. Yes.
Now, Julia, pick it up from those concerns that have been raised by members here, as well as the members of the National Assembly who had raised questions if SHA is ready to be rolled out. And as you responded to that, we're talking about some of these teething problems, I should say, you have just witnessed. So how are you addressing those issues ahead of this rollout?
Okay. Thank you once again. I would wish to say that with a new thing and new changes, you will expect hiccups and questions, but they were not in a way that they were not foreseen. These are issues that were foreseen, and like you heard the PS clearly say, that the two systems will run concurrently. This morning, I had to ensure that the system we normally use to approve patients' access to healthcare is working. And we have established, yes, it's working. Hospitals are able to send their requests. We are able to respond. So the two systems are working concurrently, and with time, one will live to the other, because it has to be one system that they're talking about. If I may come to my colleague here about emergency services, we are happy to say that the Social Health Authority has this time braved itself and walked into what we call emergency services ambulance evacuation, which the National Health Insurance Fund was not able to, based on sustainability and the funds. And so in this one, we are looking at evacuating a Kenyan. You do not have to be registered, you do not have to be a member, you just have to be a Kenyan within the boundaries. And once you get an incident or an accident, the process seeks to transfer you to the nearest healthcare facility. So it's to the facility from your point of incidence, or from a facility to another for better care. What are we looking at here? We are looking at evacuating emergency cases. The reimbursements and the tariffs are as per kilometer, and it is accessible to all Kenyans. We are looking at managing this through a national ambulance center, which will be established as per the regulations. So partners and all who may want to work together in the National Ambulance Call Center are welcome for the benefit of many. Now, my colleague here mentioned the pretty much advantages and the benefits that the Social Health Authority is bringing that is a bit different from the National Health Insurance Fund. We have a couple of them. We are now into critical care. That is the HDUs and the ICUs in a bit more defined way. Assistive devices, where we have hearing aids and walking crutches and all that we never used to be able to finance. The palliative care that he was mentioning, where you get your terminal care, especially for people who have terminal illness and they just need a setup that is more of a hospital-based. We are now into screening. SHA is willing to walk into screening. Rehabilitative services have been improved. Of course, we were there, but now it's a bit better. We've mentioned emergency evacuation services. We are willing to start and gather our data with the 18-year-olds and below when it comes to eye health, opticals and frames, the oral health services as well, which was something we were not doing. And then also the last expense, at least some 5 days when the body is still in the mortuary. So all these with the regulations are things that will be set up and take off gradually and as we can sustain. What we used to have that has now been enhanced are like the cancer services, the surgeries, that then the free maternity, the tariffs have been increased. to hospitals that are willing to offer the imaging services, even the mental health. So there's quite a bit there and quite some work to do that we're looking forward to slowly integrating in our systems and bettering access to healthcare.
Okay, I have a question there in terms of how you decided to allocate when it comes to dental, optical, some of those key areas. But Olale, you've just heard from Julia. She's talking about it is already factored in within SHA. Now, how can you ensure that the patient who's there on the ground, linking up with your facility, receiving that treatment or taken to a health facility to receive a treatment without any hiccups along the way in terms of ensuring that if you have not paid, we cannot take you to hospital?
I think we can leverage on the technology that Ambulex has, and I know that SHA also has put some funds for technology, and they're really working on that. So we can leverage, for example, at Ambulex we operate with a simple app that is available on iStore and also on Google Play, which any ordinary Kenyan is able to download, register, and we can integrate this together with what SHA is already using so that they can get this on the back end, so long as all the necessary details are provided. So that is one way to know who are the subscribers, one, and two, what amount have they paid, and up to what level of service are they getting because of what they are paid. So I think leveraging on technology.
My question is,
yes,
you do know how it happened with NHIF.
Yes.
You have to wait at least, let's say it was a day or even 2 days until that money is remitted. So are you willing to take those patients to the hospital and wait for SHA to remit the money?
Absolutely. Yes. That is the kind of partnership that we want. We want good representation. We want meetings with them so that then we are sure that this is the process we can use to follow up for payments and even those who are registering just as new partners. Yeah.
And as a health specialist, Daktari, tell us what is in there for your patients that you load but can be improved on?
Yeah, so what is in SHA that can be improved on, as I mentioned before, is that for us to achieve the best primary health care, we need to, SHA may want to consider establishing the hubs within the counties, that is from sub-counties to counties, and to do that throughout the country, and that will enable the operationalization and for the beneficiaries to maximize on the benefits given by SHA. I wanted just to mention, as I look at SHA, it will enhance quality of care, and by quality of care, I mean in terms of safety, in terms of timeliness, because those are provided for, in terms of efficiency, because the way it is structured is to both improve the allocative efficiency and technical efficiency, the productivity. And the other thing is, and this is very important in SHA, is the equity component. There are a lot of barriers to accessibility of health services, and some of those are because we have been having weak linkages between the spokes and the hub. And as I mentioned before, the spokes includes the community health promoters, to the dispensaries, to the level 3 health facilities, and the hub, which is level 4. So maybe if SHA can concentrate on strengthening the MDT, the multidisciplinary team.
Okay, we'll come back, hold that thought, and Julia, I'll allow you to respond as well. I want to take our viewers back to the Kenyatta International Convention Center, where the Agriculture Sector Network is currently ongoing in conjunction with the Ministry of Agriculture. I'm being informed the Cabinet Secretary is already there. Let's listen in to the conversations that are happening in terms of the plastics exhibitions.
So thank you very much indeed. I wanted to thank the EU, I want to thank AGRA, I want to thank Uplift Agriculture, VP Group, who's Mr. Jonjo is here, Farm Innov, Cooperative Bank Lattice, and of course my own company, Elgin Kenya, Without partners and donors and money, very few things happen. So I want to thank all of you for your support over the past few years. And finally, ladies and gentlemen, there are 3 exceptional human beings who have spent days and nights getting this thing going. And I wanted to quickly recognize them. Agatha Thuo, who's our CEO, I want to recognize her. Agatha, please stand up to be recognized. Now, this lady single-handedly has managed ASNet, I do not know how. Supported by Winnie. Winnie, where are you? Is she around? Winnie and Henry Njenga. Henry's there, he's our FC. And we have one more person, policy, who's not here this morning, but can you imagine, ASNet is run by these 3 to 4 people who work 24/7, and they're so hardworking. I just don't know how they do it. So I want to thank personally Agatha, Henry, and Winnie for really the wonderful support you give to us. So ladies and gentlemen, my hope and prayer is over the next 2 days, we have much more discussions, much more thought process. At the end of it, tomorrow afternoon, we come up with a 10-point plan on how to improve research, innovation, and technology in agriculture. Thank you very much indeed, ladies and gentlemen, and fruitful discussions. Thank you. Ladies and gentlemen, it's my great honor to introduce our CS, Bwana Karanja, to you this morning. Some of you already have met him in your various networks, but let me quickly formally introduce who he is. Bwana CS is one of those incredible technocrats, brains in agriculture. He's been 35 years in the public sector, both locally and internationally. Interestingly, he started his career as an extension officer, moving up to a planning officer in Ministry of Agriculture. He served in the Cocoa Board in Ghana, Inter-Africa Coffee Organization, research fellow at the Tegemeo Institute. Then he joined the World Bank in 2003 as a senior economist. He's done various consultancies for USAID, EU, World Bank, Government of Kenya, across here and across Africa and internationally. And fascinating enough, and which really, in my mind, tells me he's just the perfect man for the perfect job, he's published 26 papers and book chapters. So I think we have in our midst a real professional agriculturalist. After a very, very long time, we feel so confident, Bwana CS, that you're with us, you're holding our hand, you are our father of our sector. And already in the last 1 month, he's given us 2 appointments to see him. So we know he has an open door policy. He's a man who will reach out to all of us, who will collaborate with us, who will talk to us, understand our world. So I'm very, very proud and happy, Bwana Karanja, that you have accepted to be our chief guest. And I welcome you on stage. Thank you, sir.
Thank you. Chairman ASNet, my friend Dr. Bimal Kataria, board members, trustees, the CEO of ASNet, who happens also to be my classmate, development partners, ASNet partners, representative of the county governments. We have the private sector players and captains of the industry, the academia, farmers present, our distinguished guests, ladies and gentlemen, good morning. It gives me great pleasure to be part of the 4th National Agricultural Summit here in Nairobi. I am also honored to recognize the presence of you all for gracing this important event, cognizant of the fact that most of you had various commitments, but you decided to be with us here today. I want to thank the Agriculture Sector Network, ASNet, who are our partners. We regard as our partners for the invitation and for the organization of this summit. Ladies and gentlemen, the drive to increase agricultural productivity, provide safe and nutritious food for a growing population, and expand our international markets for our Kenyan produce is the inspiration by which the government launched what we call the bottom-up economic transformation plan, the BETTER. And agriculture remains the #1 pillar in BETTER, and we are greatly appreciate the ongoing activities and impacts which has been realized in some of the areas. As we engage in discussions during this summit, I note that the theme for the 2024 National Agricultural Summit is embracing sustainability, innovations, research, and competitiveness in agriculture. This is a fitting theme, as it
Well, there you have it. The Cabinet Secretary for Agriculture, Dr. Andrew Karanja, is currently addressing the 4th National Agriculture Summit that is currently happening at the Kenyatta International Convention Center on how Kenya can ensure some of its produce go to the international markets and how you can better grow yields within our farms and ensure that our farmers get the appropriate remuneration when it comes to their produce they produce in their farms. Now, I'm being informed our reporter Felix Q is following on that particular bit and will duly inform us in our subsequent bulletins. We're still carrying on with our conversation here. Today it is the rollout of the Social Health Authority, and of course the ministry issued a statement which I'll be reading later on, but we do have a representative here of SHA, that is Julia Ouko. She is the division manager of SHA. We also have Mr. Olale Ochieng, the chief operations manager and a clinician at Ambulex. We also do have Dr. Dan Ogola, the CEO and founder of Matibabu Foundation Kenya. Julia, I'm coming to you. There were those issues that were raised by Olalehi and Daktari, and also talk to us on how SHA arrived at distributing these funds when it comes to dental care and other various services that will be offered or benefits Kenyans will get to see under SHA.
Thank you. The two concerns majorly were optical and the oral health services. So in the optical, SHA envisions a household cover, and the provision of services in a hospital that is under level 2 to 4 as per the Kenya Essential Package of Health. So in the eye health, we are looking at the tests, we are looking at the refractive errors. So that is a good beginning. When it comes to the oral health, in oral health, we are looking at financing consultations, tooth and gum diseases. We are looking at tooth extractions and all that. That is just in your oral health. So let's just get that clearly. When it comes to apportioning, there are lengthy meetings and consultations as to how much we are looking at in terms of collecting. Remember, the Social Health Authority comes with 3 funds. The Social Health Authority establishes the Primary Healthcare Fund, it establishes the Social Health Insurance Fund, and it establishes the Emergency, Chronic and Critical Illness Fund. So the modalities around financing of the funds were high level, and every discussion and arrangement and possibilities were discussed. And so what we consider, how much are we going to get, is what informed how to apportion it to the various benefit services that the Social Health Authority was willing to walk into. They were also informed by previous utilization trends that was in the NHIF. Like if we are walking into this package, what is the population that is likely to access this service? How much does the service cost? Then how much do we have? And the calculations would go on. So the economists, government economists were all there. The actuarials from both government and even the National Health Insurance Fund. Our benefits team, we were also there. And there was all that information to help us know what to apportion where. Yes.
And let me come back here to Olale.
Yes.
You've just heard clearly from what Julia has stated. For practitioners such as yourself, people who are running these organizations at the end of the day that will cater for the services of the patients who are out there, are you still going to ensure that you wait for these funds, give the service, but there is that assurance that SHA has given at the end of the day they will pay?
I think yes, because it would be very unethical also to deny Kenyans service like the ones that we offer also. And then simply because they haven't made payment when SHA has given us their word that they're definitely going to remunerate. So I think we'll definitely wait, and we're very much willing to work with SHA towards that.
Daktari, health practitioners all over the world, especially here in Kenya, opt to work with private insurance mostly. as opposed to what governments are providing. So what can SHA learn from the private sector that can be incorporated to ensure that health specialists such as yourself at least can give out the services knowing clearly you will be paid at the end of the day?
The private health sector, especially the third-party payment mechanism from that are private, there's an assurance, of course, between both from the government, as in SHA, and the private health insurance. The only difference is that in terms of efficiency, the time to releasing the money is shorter for the private insurance compared to the government. The other thing is that the private insurance give more reimbursement, as it were, compared to the government. But again, if you are to look at the intention of the government, is not for one to overly benefit from by offering their services, but to also consider the people who cannot afford it. Health is a public good.
Yes.
For the private, it can be a source of making profit. Yeah, so there should be a balance between what SHA is doing and what the private insurers are doing.
And Julia, there you have it. That is the elephant in the room. How can you assure these health practitioners and health institutions that they will be paid at the end of the day? You saw what happened with NHIF in terms of reimbursing the services that have been provided.
Okay, correct. Probably I would start by saying in the new SHA regulation, the new SHA law and regulations as well, SHA has been put as the first payer, which was not with the National Health Insurance Fund. So that therefore means when a member accesses services that the SHA is financing, the SHA takes the first burden. And that is, I think, a good thing for I don't know, for private insurance, but it's also a surety to the members of SHA and contributors as well that their bills are being taken care of. However, having operated in Kenya for close to 60 years, you cannot doubt a public insurance payment. We have those arrangements in the contractual obligations that we have with healthcare providers, which is now going on. Healthcare providers are now receiving the contracts and signing them up. So in that arrangement, we define how we are willing to undertake our payments, our payment options, our payment methods, and how and when we shall do our payments. So hospitals are confident that in as much as SHA has taken over NHIF, that will not affect how we have been relating when it comes to payment. Yes.
And the person who just joined us is Dr. David Mundia. He is the Deputy National Chair of the Kenya Medical Practitioners and Pharmacists Dentist Union. Thank you so much. That is KMPDU in short. We'll be talking to you in just a few, Daktari, but I'm being informed there is an event that is currently ongoing in terms of the Principal Secretary for Broadcasting and Telecommunication, that is Professor Edwin Kisiangani, who is presiding over the program for the signing of a performance contract. Once we do get a hold of that link, we'll be going there. Daktari, as we are setting you up, let me come back here to Olale. Is that enough assurances? And going forward, what are some of the solutions that you can give to SHA to make it worthwhile at the end of the day for the taxpayers?
I think the biggest issue, and first of all, let me say that I like Julia's response. You can always rest assured for a public payment. And I think the only other issue that has been there, at least from the clients that we're meeting, has been the affordability and availability of that actual service. So there are those individuals and even some of the corporate institutions that feel like 2.75% is a lot. And then historically, we've also had very few services or no services sometimes. And also when it came to historically, again, NHIF partnering with private facilities, sometimes they would just refuse, or they would really limit the kind of, say, a prescription that you would get to 1 or 2 medications. And that is one of the things I think they need to look at, actually, and see that the service that is available in public facilities under SHA is almost the same kind of service that is there in the private facilities. Yes.
And Daktari, coming back to you, we are talking about earlier on before we went to KICC, we were talking about some of the benefits that can be gotten from the Social Health Authority, especially given that you are a health specialist. As you respond to that similar question, you know what happened to NHIF. Hospitals and practitioners were taking advantage of the funds, of the public funds. Even NHIF itself, which is currently today before, or should I say the new authority is before the Parliament itself. So are you confident enough that those issues have been addressed, and as a practitioner, are you ready to receive these patients who are under this new model?
Yeah, we are ready to receive the patient. Health is a human right. You have alluded to something very important. It's called supplier-induced demand, yes. Where you will find the practitioners telling people to carry out too many tests that are unnecessary. Too many tests that are unnecessary. So it will be SHA's responsibility to guide the healthcare providers on how to deal with the supply-induced demand, the SID. Yes.
Julia,
yes.
We're talking about some of the new modalities. So what is the major difference between NHIF and SHIF, including the question that I've just asked Daktari? How do you ensure that the public trust is rebuilt? Because we all saw what happened in NHIF.
I want to say at this point that as a member of NHIF or now SHA, what you look for is, I have contributed, so I expect service. And so at the point of service, the difference needs to be very clear. So you find, like now, the biggest thing that SHA has brought on board, and I wish to applaud government on that, is that we are going to have the same tariff across. So it does not matter where you have accessed the service, but as long as that service is reimbursable, then it is going to be standard across. And so we expect, therefore, that the other end, who is the service provider, the healthcare provider, is able to give quality service. Remember, the government has gone as far as enacting the Facility Improvement Fund. So with that, we expect that the funds that are coming from SHA are zeroed in the facility.
Yes.
And so the facility may not have a reason why they are not plugging back that reimbursement or whatever they have been paid back into ensuring that there is quality of care. So that is a big difference. And then again, we're also looking forward to that system that will be able to do quite a bit of checks and ensure that what is actually being requested was done and is what is being reimbursed. So there's a big move in that we are now doing equity as should be done, and that the facilities have been enacted through law to now zero in on their funds and give quality care, and that they have a system that is going to assist to ensure that this is done.
Now, we do have a practitioner on the ground, and he has members on the ground. Dr. David, thank you for joining us. He is from the Kenya Medical Practitioners, Pharmacists and Dentists Union, which is the KMPDU. You've just heard from Julia. She is a representative of SHA. She's saying that in the Facility Improvement Fund, those funds that are collected from those health institutions, at the end of the day, they will go back to the health institutions, because you know what was happening previously. Some of those funds that were collected from those health institutions were allocated to other functions. So is this a plus for the practitioners who are working in those institutions?
Well, thank you. And my observation is that the county governments have a duty, just like the national governments have a duty. And it seems like the county governments don't want to do what is right, and that they have to be micromanaged to do the right thing. County governments receive money from the National Treasury to allocate and distribute across as many services. So now the Facility Improvement Fund, that law, it's brought in to ring-fence funds at the hospitals. On the basis that county governments are unable to prioritize funds to the healthcare sector. It's like creating a law to probably ring-fence money for roads, or creating a law to ring-fence money for agriculture. So we are doing a lot of too many laws, and there is something wrong with the leadership. I don't understand why, because if services are devolved and you have a duty as executive, as a governor, And you have to deliver on the principles of what your people elected you to do. You just have to deliver them. So a law was created to try and lock funds at each public hospital so that they can be used at that local area to improve the service delivery. So it's a good concept. But again, there are other persons who bring up another issue that it is in clash with the Public Finance Management Act. So we're yet to evolve to that point whereby now it says we lock this money, it needs to go back, then comes back to the county for it to be redistributed. So we're yet to understand those conversations.
And of course, it was passed through Parliament. These were different bills, now there are acts in the Facility Improvement Fund. Maybe tell Kenyans what was lacking before in terms of when those monies came, the monies that were collected from the hospitals, where did they used to go and what are they required for? So is it to pay the workers who are working there? Is it to buy equipments within the health facilities?
Okay. Well, in Kenya, again, we're in a very interesting country. You have resources, but prioritization of resources becomes very problematic. And money for HR, for a long time, that's the human resources for health, has never been put in a particular vote that this is the money that just goes to the HR salaries and all that as allowances. This is the money that goes to drugs. This is the money that goes to maintenance. This is the money that goes to health promotion. So there is a mixed mash of all that. So you only get the full money, and it's up to you to decide how to allocate based on the number of persons you have on your payroll, or maybe the drug orders that you've got, and the number of projects you want to run as health promotion activities. And most persons, most of the county governments, what I've seen, they're into construction projects. They'll put up blocks, but they never plan for HR, they never plan for service delivery. And for that, to them, that is what they'll take pictures and say, this is what we've done, this is development. But it's blocks and blocks without people, without services. So that is not right. So that's why now it's decided to have monies locked with that Facility Improvement Fund to have services delivered to the people. Now this money can come from user fees or from many other models of financing. So now we have, previously we had NHIF.
Yes.
Now it is proposed you're supposed to have this money coming from SHIF. Now these services are supposed to be optimized so that when you provide more services as a facility, you get more collections. And from these collections, you're able now to self-sustain like a small private business. But it is a public entity.
Okay.
So that's the whole concept of
I'm well informed. We are running out of time. Let me start on this end. Mr. Olale, give us your final remarks in terms of SHA, given that it is being rolled out today. And what can you tell the viewers right now in terms of this fund itself?
Well, just a few things, or one thing. I think from where we sit, we still believe that SHA is one of the best things that has happened to this country. But we want more public participation and a lot more tests or controls just to make sure that we have the right number, we have the right data for us to be able to make those decisions. And then, of course, from the type of clientele that I deal with, if we could revisit the 2.75%, but at the end of the day, I would still make a clarion call to every Kenyan to register so that we are all on the same platform. Then we can have a discussion when we are all on the same boat, as opposed to us having divergent opinions or positions.
Julia?
Thank you very much. I would call upon Kenyans not to shy off from the Social Health Authority. Kindly proceed to register. Let's pull together towards this healthcare plan that we have. We are calling upon healthcare providers, do not shy off from providing services. Social Health Authority has got your back. Kenyans, Social Health Authority is willing to work with you in your healthcare issues, terminal or not, critical or not, we should be there. So let's just pull together, try and understand it, give each other time, place. It is well meant. Every other thing that could not be right, let's bring them out and let's just work together to ensure its success.
Daktari?
Thank you so much. Kenyans, let's register for SHA. We have been desirous of having universal health coverage, and the government has formulated policies like Universal Health Coverage Policy 2020 to 2030, Kenya Health Policy 2014 to 2030, and Kenya Vision 2030. And to achieve this, to achieve our dream of having universal health coverage, then SHA is a great tool that we can use to realize those government's policies. let's register for it.
Finally, Daktari, I know you joined us a little bit late. Give us your final remarks.
My point will be for the two governments, the two levels of government. They are the drivers of this project. And if they fail to prioritize the sector, it is just going to crash. And as it is right now, we are having only the formally employed stabilizing this fund. And if these people get fatigued with contributions, with non-matching commensurate benefits, we are going nowhere. The funds must be optimized in a way that they are sustainable. Enough funds to the PHC fund, enough funds to the SHIF fund, and enough allocations to the emergency care fund. Otherwise, we are stuck here for a long time, and that is not where we want to be at.
Thank you so much. That is Dr. David Mundia. He is the Deputy National Chair of KMPDU. Thank you for making time. I know you came a little bit late, but thank you for your time anyway. We do have also Dr. Dan Ogola. He is the CEO and founder of Matibabu Foundation Kenya. Dr. thank you for coming in. Julia, you've just heard from the stakeholders here, and Kenyans are still talking about SHA both on and offline. We wish you all the best. She is the division manager at the Social Health Authority. And then finally, Mr. Olale Ochieng, he is the operations manager, a clinician as well at Ambulex Solution. Thank you, gentlemen and lady, for making time for us. I'm also being informed that the Principal Secretary for Public Health is currently in Kisumu for the SHA rollout, and we'll bring you those live images in our subsequent bulletins. But for now, that concludes our conversation. Carry on with the conversation, of course, both on and offline. These are critical issues touching on matters to do with health. You've just heard from the representatives and stakeholders within the health sector. It is upon you to go and register under this new authority, given that it has replaced the National Hospital Insurance Fund. My name is Abdiaziz Hashim, but before very own Kasichana Masha joins you for Kurunzi Mashinani, we do understand the function of the Principal Secretary for Broadcasting and Telecommunication, that is Professor Edwin Kisiangani, is presiding over the program for the signing of performance contract. We leave you with those live images, and good morning for now.